Well, good evening, everybody. Can everyone hear me? Lovely. Thank you very much. Perfect. Welcome along, guys. Another ECG webinar, number 3 in the series. So I'm just going to give the folks who are just arriving some time to come on in. So thank you all for coming along again, and I hope you've all been enjoying the lovely bank holiday weather in a responsible way, of course. Fabulous. Just going to give it a minute or two before we plough in, just to let anybody arrive that needs to. Very good, Matt. Fabulous. Okay, so here we are, third episode. For those of you that haven't been along already, I'm a paramedic practitioner by trade. I work in a GP surgery. Also do some bank work with a couple of the local ambulance trusts in the area. I have a special interest in ECGs and anything to do with cardiology. We kind of decided to put these webinars together for some CPD during lockdown, whilst everybody is kind of restricted on what they can do. We thought it was a good idea to try and run through some of these subjects. So welcome along. I can see a few familiar faces in the crowd. So welcome back. Thank you for coming and supporting this. So a little bit about STC Training Solutions. If you don't know, we're a company that was set up last year initially to provide first aid training. And we've since become registered with QualSafe. So we deliver the FREC range of courses and all the bolt-ons that those go with, and also we do some BLS and ILS and now webinars, CPD products for healthcare professionals and so on and so forth. So this is just one of those things that we do. The ECGs is the first in a few series, hopefully, and we're going to be looking at a few other subjects going forward. So there'll be more information to come on that. So. Lovely. So apologies first of all. So Charlotte, who is usually manning STC admin, is out saving lives at the moment and has got a late job. So as is the way. So I'm kind of manning everything here. I can see the chat, but I might not be able to respond quite as quickly as Charlotte was doing the last couple of weeks. So I can see you, and I'll just answer by voice, I think, rather than that. So. Just gone 7 o'clock, nobody waiting to come in, so let's get going, if it wants to. Fabulous. So obviously this is subject to change, folks. We do have some upcoming courses. Word on the street is that we might be able to do some face-to-face training fairly soon. If any of this interests you, then obviously there's nothing to pay until the course has been confirmed, but do give us an email at sales@stctrainingsolutions.co.uk, and because you've come across this through our webinars, we'll pay the VAT for you if you book through that email address. So we're running in the next month, hopefully, an ILS course, medical gases for the FREC 3s out there, life-saving medications for the FREC 4s, and hopefully a FREC 3 initial course over 2 weekends, starting at the end of June. Obviously, this is all subject to change, but if any of that interests you, then drop us an email at sales@stctrainingsolutions.co.uk. As I say, if you quote STCPD 20, we will be covering the VAT for you. Obviously, once we know for sure whether the courses are running, we'll get you sorted out. So that's the plug over and done with. We'll get on with the webinar this evening. So again, we want this to be as interactive as possible. You can chat with us through the Zoom chat. I can see it. As I said, Charlotte's not here at the moment to answer, but I'm sure she'll drop in before the end. WhatsApp I've got open again, 07535 382223. You can tweet us at STC Training Limited Ltd. And of course, you can email us webinars@stctrainingsolutions.co.uk. We're going to use Mentimeter again this evening, so make sure you've got your smartphones to hand and you can vote on those. Menti.com and put in the code once that comes up. Fabulous. So those of you that were here last week We looked predominantly at lead 2 rhythms, and then we finished off by talking about AV nodal blocks. So this evening we're going to follow on from that. We're going to look into something called cardiac access. We touched upon it in the first episode back 2 weeks ago, and we're going to go into that into a little bit more detail this evening. We're also going to look at some of the bundle branch blocks, the fascicular blocks, or hemi blocks as they're often called, bifasicular and trifascicular blocks. I seem to remember last week I said if you see a first degree heart block, you want to bear in mind that these 2 terms, bifasicular and trifascicular blocks, so we'll go into what that means. And then we're going to finish off today by applying some Sgarbossa's criteria to a left bundle branch block, which leads nicely into next week, which will be on acute coronary syndromes and the like. So we shall get going then in that case. So let's go back to last week then. So just a little case study to get the minds in gear. So you've got a 56-year-old obese male walks into your surgery, wherever you are. His past medical history is he had an MI last year, 2 stents were fitted, he's hypertensive, hypercholesterol, and type 2 diabetic with some ischemic heart disease going on. You can assume he's medicated as appropriate for those. He's told you he's got a week-long history of palpitations. They come and go at random, but he's otherwise well. What would we like to do with this patient? First of all, he's sitting in front of you. I think his cardiac risk factors are ultimately quite high, I would suggest. What should we have a look? Pop in the chat, guys, be as interactive as we can. Vital obs, 12 lead ECG, lovely, we're on the right lines, perfect. So we're going to do some basic observations here. Nothing that remarkable there. You notice that his heart rate is 80 and regularly irregular. So that's really the only abnormality there. Borderline hypertensive, borderline tachypnic, everything else is pretty good. His physical examination is NAD as far as you can tell. So we print off an ECG. There we go. We have the ECG machine to hand. Have a good look at this, folks. So this is a chap with palpitations, a regularly irregular pulse. What are we thinking is going on here? We're going to use Mentimeter to answer that, so I'll just get that slide loaded up so the question appears. You can log on. What's the ECG diagnosis? So we're going to go to menti.com, 330154 is the code. Bear with me, it's not active for some reason. Let's activate it. Start voting on there, folks. I'm just going to head back to the slide so you can if it will let me, so you can see what it was. Okay, there we go, finally. So that's the 12 lead ECG. Voting should be open on menti.com. What do we think this ECG is showing us? Pop your votes through. So is this first degree AV block? Is this a Mobitz 1, a Mobitz 2, third degree AV block, or atrial flutter? There it is again, folks. It's a shame we can't have the question up and the ECG at the same time. We're trying to work on a way of doing that. That's it. Have a vote, menti.com, 330154. Perfect. Let's see where you guys are going. Okay. Anyone else want to throw in there? Lovely. Okay. So nobody's thinking it's third degree, nobody's thinking it's atrial flutter. The majority of you are thinking it's first degree AV block. I'm going to cast your minds back to last week, and we're going to just talk about the different types of AV block. So this is the ECG that came off. Remember, folks, first degree AV block is a regular rhythm, and we see a constantly increased PR interval. So this ECG here, you've got leads. This is your standard 12 lead view in the top here. This rhythm at the bottom here is your lead 2 rhythm strip. Have a look at what the P waves are doing. they're not constant, they are changing, so that rules out first degree AV block. So it's not third degree AV block, as none of you voted for that anyway. Third degree would be total disassociation between the atria and the ventricles. So we're talking about a second degree block here. Now the way we tell the difference here is what's happening to the PR interval. So a gradually increasing PR interval to the point of dropping a beat is P's on the run, Mobitz type 1, and a constant PR interval which randomly drops a beat. P's marching through Mobitz type 2. So in this case, this is Mobitz type 1. So 30% of you that got that right, well done. Let's just get you into the groove. So if you remember back to last week, what are we going to do with this patient? Some of this is a bit of knowledge about NICE guidelines and the like. So we've got this chap sitting in front of you, just diagnosed a Mobitz type 1 block. He's on the run, Mobitz type 1. What are we going to do with him? He is symptomatic, he's got some palpitations. Have a vote. And as always, folks, any questions as we go along, there's anything that you're getting stuck with, then throw it into the chat when we come to a kind of a natural pause like this, while we're waiting for things to go through. I can answer them for you. Fabulous. Let's see where we're all going. The more of you that vote, the better this goes. So keep those votes coming in. Okay. Well done, folks. Thank you. Okay, so we're all going for the majority of us thinking ambulance to A&E or CCU. By admit to hospital, the 8% of you, I'm suggesting we talk to the MedReg, for example, and get them admitted. Urgent cardiology referral, 31% of you, routine cardiology, 15% of you, no further action, none of you are saying that. So Mobitz type 1 rhythm is actually a relatively benign rhythm, so hopefully it will be no surprise that a routine cardiology referral, that's all we really do for these patients. So they do need consideration for a pacemaker, but less so than perhaps somebody with a Mobitz type 2, which is the more unstable of the rhythms. So if we talk about these options, no further action would be applicable to somebody with a first degree heart block, for example, because you generally don't develop symptoms with those. Routine cardiology referral will be for somebody like your Mobitz type 1, so a gradually increasing PR interval to the point of a drop beat is not an emergency. That will be seen routinely by cardiology. You would probably want to get somebody with a Mobitz 2 or a 2 to 1 or a high 8, well, 2 to 1 at least, seen fairly urgently by cardiology. The admit to hospital is rarely going to be an appropriate course for any of these patients, and obviously somebody with third degree heart block or a high AV block, somebody hemodynamically unstable is going to go to A&E or the CCU by ambulance. So hopefully that makes some sense. That's just a bit of nice guidance, or local guidance may differ slightly, but you're going to be looking at one of the cardiology referrals in those cases. So well done to the 15% there. Oops. Okay, right, so vectors, hopefully fabulous. So the palpitations would be nothing to worry about. So Chris, we would do some bloods, but no, in that case, the palpitations are more than likely going to be a result of the drop beats. Realistically, it's one of those scenarios where we've got to have a look at how stable a patient is, how well a patient is. Otherwise, palpitations on their own can be caused by a load of different things, but we'd certainly be doing some bloods just to rule out anything nasty going on there. But he would be, it would still be a routine referral to cardiology. You could possibly step it up to urgent if you were overly concerned by anything you saw, but actually Mobitz 1 is a relatively benign finding, albeit it generally occurs secondary to ischemic heart disease, so they're definitely going to want a cardiology workup. I hope that makes sense. So refreshing on cardiac axis, this slide from the first week, a couple of weeks ago. So we learned then about the electrical output of each individual myocyte, and these little black arrows that we see floating around in the heart here are signifying the individual myocytes firing off. And what we do in calculating axis, all we're doing is figuring out where the general trend of that electrical activity is occurring. So when we add up all of these individual action potentials from the myocytes firing off electrical current, if they had a general direction, a mean trend to them, where would that cardiac axis be pointing? Now, it should be no surprise that obviously with the electrical activity in the heart originating from the SA node, traveling down the internodal pathways to the AV node, from the AV node down the His bundle of His into the branch blocks and off to the Purkinje fibers at the apex of the heart. It should be no surprise that predominantly the electrical axis moves in a kind of southeasterly direction if this were a map. So where this colourful arrow here is pointing is, generally speaking, where most people's axis will sit in a healthy heart. Okay, and remember from last time we said that the ECG leads are effectively cameras looking in at the heart along these kind of trajectories. There's a frontal plane of the heart. We're looking up effectively from the left leg in the case of lead 2 here, looking directly across the heart from the left hand side here. From the right shoulder down to the heart, from the left shoulder down to the heart. Hopefully that makes sense. So we're looking at this axis in a two-dimensional plane, and these cameras here have been marked up by the individual leads to give you an idea of which lead is actually looking at which part of the heart. So you have your true, these are, when we talk about cardiac axis, we generally only talk about the two-dimensional frontal plane axis. And to calculate that, we only need to look at the limb leads. So your true limb leads 1, 2, and 3, and your augmented views, so right, left, and feet, AVR, AVL, AVF, are the 6 views that the limb leads give you. And these are the ones that we use to calculate our ventricular axis. It's worth pointing out at this point, the atria do also have their own axis, and we will talk about those in atrial anomalies a little bit later because they're quite interesting to think about. And for those, obviously, we just look at the P waves. But for this, we're going to look at the QRS complex, and we're going to look in these 6 views. So you'll recognise this slide as well. So from the first week again, how an ECG machine actually works. It turns the vectors into waves. So looking at this camera on the right hand side, first of all, if this was lead 2, for example, looking straight at the heart, if you have the general axis heading straight for the lens of the camera, it will show as a positive deflection. So if the current is moving towards the positive axis, and the positive axis is where the camera is sitting, then it will give a positive deflection on the ECG. And you can see here a wholly positive QRS complex. Okay. Obviously, in reverse to that, this camera on the left here is looking, so for example, AVR in most cases will be looking at the heart from the right shoulder, and ultimately is getting the cardiac axis moving away from it. So when cardiac axis moves away from the positive towards the negative, you get a negative deflection. Okay. And obviously we have some variations on that. So the one we're going to focus on this evening is the current that's moving perpendicular to the lead. That will give a biphasic or an isoelectric wave, so equally up as down, and that means that the current is moving perpendicular to the positive electrode of the ECG lead. Whether it's moving left to right or right to left, we don't necessarily know just by looking at this, but we'll come onto that in a little bit more detail. And obviously these are just put in for completeness. So obviously if the vector is moving generally towards the camera but not directly, you'll get some negative deflection. And likewise, if it's moving predominantly away, but at the same time it's not moving directly away, you'll get mostly negative with some positive deflection. Hopefully that makes sense for everybody. It's just a bit of a recap from the other day. So what's normal? Normal axis in a healthy adult is going to be, so there's a bit of debate on this. So we're gonna focus on the more simple of the debates this evening, because actually it makes a lot more sense when you come to compute it. So the vast majority of textbooks will teach you that normal QRS axis is between 0, and 0 is measured off to the left of the heart here. So east, if this were a map. So normal axis is from 0 to plus 90 degrees. Obviously, it goes up to 180. So you can have up to plus 179, 180 degrees, and then it goes to minus 179 for the left-hand side there, if that makes sense. So we'll see this overlaid the heart in a moment, which will hopefully make it more anatomically relevant to you. So generally speaking, we talk about 4 quadrants. So normal axis being 0 to 90, right axis being plus 90 to 180, left axis being 0 to minus 90, and then extreme axis deviation. It's got a few names. It can be extreme axis, extreme right axis. It can be indeterminate axis. It can also be known as northwest axis. Loads of different names, and I can only assume they're called loads of different things to confuse people, because that's what we like to do in medicine, isn't it? So this area that's shaded in purple here. So if you read some textbooks, it will tell you that technically normal axis extends to minus 30. But I think it is a matter of opinion, and there are cardiologists that will debate this. So some cardiologists will say technically, an axis of minus 29 would fall within normal. Others will say, well, actually, that does suggest some underlying pathology within the conduction system, and would be worthy of further investigation. So that's why 0 is kind of always is thought of. So for the rest of this evening, we're going to talk about 4 nice, easy quadrants that go from 0 to 90 for normal axis. But it's just bearing in mind that there's this 0 to minus 30 is a bit of contentious area, and you may hear it mentioned in other training and so on and so forth. But just to be aware of it. Lovely. So what causes axis deviation? So when we're healthy, as I've said, generally speaking, the current is moving down in this general direction, generally down to the bottom of the heart and veering slightly left because the heart is angled at that left angle. So what can cause changes to that? So hypertrophy is one of them. So that's an enlargement of the cardiac muscle that's normally caused by raised blood pressure. And areas of hypertrophy will generally pull the axis towards it. If you imagine this left ventricle becomes hypertrophic because of long-term blood pressure issues, you generally find that you get an increased density of myocytes, cardiac myocytes, and they're all producing their own electrical currents. So I suppose it's no surprise that the general trend of the electrical axis is pulled off to the left, because there's more going on that side. There's bigger vectors kind of affecting that area, and the way a hypertrophic heart, enlarged hypertrophic heart, depolarizes and repolarizes, just drags this cardiac axis over to the left. So infarcts by which we mean dead myocardial tissue after an MI, myocardial infarction. Dead tissue does the opposite. So if you imagine this lateral wall, for example, has been infarcted in an MI, you generally find that the cardiac axis will veer opposite to the opposite side. So it pushes the axis away from it. Infarcted tissue doesn't conduct electricity, that's why. So that kind of makes sense. So a hypertrophic hypertrophic heart, will be densely packed with cardiomyocytes that will all be conducting electricity very nicely, whereas an infarcted area will have the opposite effect. So you'll generally get if you infarct the lateral wall, you'll generally get a bit of right axis deviation, if that makes sense. So we are going to talk about infarct a lot more next week, our acute coronary syndromes lecture next Monday. So branch blocks, we're going to talk about those obviously in quite a bit of detail this evening, but a branch block in generally causes a left axis deviation. So what we mean by a branch block is a block in the, so we've talked about AV nodal blocks, which are blocks in the AV node here and problems conducting the signals from the atria down to the bundle of His. What we find with bundle branch blocks is that they're a conduction issue in one of these bundle branches. So here's the right bundle branch, travels down the septum and then spreads down to the Purkinje network, the apex of the heart. We have the left bundle branch, which we know splits into the left anterior division and the left posterior division. They're also known as fascicles, which we will call them this evening. So when you get a blockage within the bundle branch blocks, what effectively happens is you cut off this really fast network of transporting electrical signals, or should I say transferring electrical signals from cell to cell. And what happens is the cells will still depolarize, but they'll do so in a bit of a slower, less coordinated way, and that's because they're not getting this coordinated signal through this right bundle. For example, if we're talking about a right bundle branch block, and they're depolarizing kind of from their neighboring cells, and that's a little bit slower, and it does affect the general direction in which the cell depolarizes. So when we find that the right bundle is, well, we'll talk about it more in detail later, but it's just kind of bearing in mind that if you close off this network here, the cells all down here will still depolarize, but they'll depolarize in a different way than if everything was working properly. And of course, the same is the same for the left bundle. And generally what we find is that both ways you get a bit of a leftward axis deviation. The left of the heart tends to dominate in both cases. So we'll talk about those in a bit more detail after. Hopefully I haven't lost anyone so far. So the hexaxial reference system. So this is always a bit it fills you with dread a little bit when you first look at it, I think. So this is how we kind of calculate axis. You may have seen this circular disc in publications before, any training you've done in the past. So it's effectively splits the cardiac axis into 4 quadrants. Again, this is the simplest way of working. So 0 to 90 is your quadrant down here. 0 to minus 90 is your left axis deviation. Plus 90 to plus 180 is your right axis deviation, and of course your extreme right axis deviation or your indeterminate axis up here in the northwest quadrant, which is quite rare, but we'll show you an example of that a bit later. So how do we calculate cardiac axis? Well, effectively, this little hexaxial reference system here allows you to calculate where the leads are seeing the QRS complex is coming from, if that makes sense. So we've talked about in a normal cardiac axis, so your general vector, general mean kind of electrical current from the heart is traveling down in this general direction, out between 0 and plus 90. And the leads in this area it will be the ones that we'll use to check that that's true. So if you have lead 1 looking at the heart from this side, we have AVF looking at the heart from this side, and we have lead 2 looking at the heart from this angle. If the general axis of the heart is traveling in this direction, it would make sense that all 3 of these leads are positive, would it not? So you've got current coming towards the cameras marking the positive electrodes of the ECG leads. So the general electrical axis is traveling in that direction. We should have generally positive leads in all of those views. When we start to see that isn't the case, then we can figure out by looking at the relevant lead. If you see that it's called a hexaxial because there are 6 lines interdivided, they're all equidistant apart, and that gives you 12 sections, if you like, that the ECG axis can be in, and we'll look at how we figure those out. Lovely. So when we first estimate axis, and for all intents and purposes, this is all that's necessary. Certainly in the pre-hospital environment, you don't need to go into loads of detail about where your axis exactly is. It's more just to know: is it normal? Is it rightward? Is it leftward? Or is it extremely right? So for all intents and purposes, we only really need to know which quadrant our axis comes into. And to do that, if you imagine this is lead 1 looking in at the heart, this is AVF looking in at the heart, they themselves make the quadrant in which normal axis has to lie. So it makes sense that we only need to look at those 2 leads. So AVF looking in there, lead 1 looking in there. We only need to look at those 2 leads to determine whether or not our cardiac axis is traveling in that general direction. Hopefully this is making sense to everyone. So, and we've said before, if the axis is moving in that general direction, both leads 1 and AVF and lead 2, but we're not going to consider that anymore because it doesn't really help the matter. Both these 2 leads are going to see a positive deflection, and that's what we see in the center here. So if you see a positive lead 1 and a positive AVF, we have normal axis, and that really is as much detail as you need to go into generally. Okay. So what if they're not both positive? Well, let's have a think about this. So what if the axis was coming down in this general direction? It's still predominantly traveling towards AVF, so you would expect AVF to be positive, but it's traveling away now from lead 1. So lead 1 cuts across the heart at this point, if you like. So everything, any general direction towards lead 1 is going to show as a positive. Any movement away from lead 1 is going to show as a negative. So if we're coming down into this quadrant here, which we know is right axis deviation, if we see a generally positive QRS complex in AVF, What are we going to see in lead one? Does anyone want to put in the comments? What are we seeing in lead one if the axis is moving away? Negative, lovely, perfect. So if we're moving away from lead one, but towards AVF, we must be in this quadrant. So there again, it's reflected here, lead one negative, AVF positive, we must be in this quadrant. And again, normally that is enough to then say that this patient has right axis deviation. Okay, let's flip it on its side, left axis deviation. So if the cardiac axis was pointing up in this direction, whoops, hang on, don't quite know what happened there, bear with me. There we go, back onto that one. Technology at its finest. So if the axis was going up in this direction, towards the AVL camera, but we're still moving predominantly towards lead one, we're going to see a positive deflection in lead one, but we are now moving away from AVF. So AVF is a point of kind of positive and negative, goes across this line here. So any deviation in this general direction is going to, oh, I do apologise folks, I don't know what's happening to the laptop this evening. So we're moving away from AVF, we're going to have a negative AVF lead. Does that make sense? So, and that's reflected in this diagram here. So a left axis is a positive lead one because we're still moving towards the camera at lead one, but we're now moving away from AVF. So we're going to have a negative AVF. And again, that is enough to say that this patient has left axis deviation. To what extent we have left axis deviation is kind of by the by for most cases. So the really rare indeterminate extreme right axis, I'll show you an example of it later, but it is quite a rare finding on an ECG, would obviously be the opposite of everything. So we're moving in this quadrant up here now, we're moving away from lead one, we're also moving away from AVF, so of course both leads are going to be negative, and that is indeterminate or extreme right axis deviation. Hopefully I haven't lost everyone there. It does get a bit deep, this axis, and it takes a little while to understand. I remember the first time I was taught it, it didn't make a whole lot of sense, but of all the ways I have been taught to deal with it, I feel this is definitely the most simple. And for most patients, you just need to put them into one of four boxes, and using just leads one and AVF, you're able to do that. Okay, lovely. So we're going to try and put that into practice here, folks. So this is a standard 12 lead ECG. So we've got leads 1, 2, 3, AVR, L and F. And obviously your chest leads, we don't need the chest leads, remember, to calculate axis. This down the bottom is just a lead 2 rhythm strip. So have a go at this, folks. What do we think the axis is of this ECG? So using that last box, so if I flick back to it, so there is a Mentimeter coming up. So just hold fire, don't pop it in the chat. Pop it on the Mentimeter in just a second. So when you're all happy with that, have a little look. So we're looking at lead 1 and lead AVF. And there is Mentimeter. 330154, same code as before, have a vote in there. So let a few of you go there. So those of you that put it in the chat, just throw it onto Mentimeter if you can, if you haven't already. Lovely. We'll show where we're at now. Show results. Okay, so we're fairly evenly split between normal left axis and right axis. Okay. So let's just have a little look back at the last couple of slides. Oops. Oh my goodness. Don't know what's going on with this tonight. There we go. So remember that so we're only looking at the two leads here. So lead 1 predominantly is negative there. So do you see what I mean by predominantly negative? So this is the baseline here. There's definitely more of that QRS complex below the baseline than there is above it. Okay. The other lead we're looking at here is AVF. So AVF, here's the baseline. Quite clearly, all of AVF is above the baseline. So we are moving towards the AVF camera. We're moving away from lead 1. So where are we? If we're moving away from lead 1, moving towards AVF, we must be down in this quadrant here, which of course is right axis deviation. So well done to the 44% of you. Matt, yes, I do like Mentimeter. It is very good. We had it on our paramedic course, actually. It was the first time I came across it, and they did use it in the classroom. It was very good to do lots of different polls and things like that. So well done, most of you getting that right with right axis deviation. Hopefully, for those of you that didn't get it right this time, you're a little bit clearer with what we mean by using the two leads. So, oops. Right, so another chance for you to have a go. So have a look here, lead 1 and AVF again, it's typically laid out ECG with a lead 2 rhythm strip at the bottom. So you're only really focusing on the 6 leads at the top left. So but lead 1 and AVF is what we're going to use to calculate this rhythm. So think about where lead 1 is. Lead 1 is predominantly positive there, isn't it? So heading towards the lead 1 camera, so off to the right. AVF is predominantly negative here, very clearly so in this case. Moving away from the AVF camera, so that's up to the top of the screen. Have a go, folks. Mentimeter again. Same code, have your votes. What was going on with that ECG? And we can welcome Charlotte to the chat. She has made it home from work. Just going to let her jump in there so she can answer any questions that come up. Lovely, let's see how we're all going on with that. Fantastic, yes. So moving towards lead 1, moving away from AVF, can only put it into that top left quadrant, so left axis deviation. Well done to 73% of you. Hopefully it's starting to make a bit of sense now. Axis is just practice. Practice makes perfect. It is a bit of it's a mind-boggling thing when you first think about it, but once you've done it a few times, it's fairly easy. Oops. Okay. We're having a few technical problems this evening with the screen jumping around all over the place. I'm not quite sure what I'm doing with it there, but okay, one more to have a look at. So lead 1 and lead AVF again. Have a think. What is the axis of this ECG? Lead 1's positive, lead AVF is positive, both heading towards the cameras. Have a think. A few of you voting already, well done. Fantastic. See where we're heading. 70% saying normal, 20% saying left axis, 9% saying right axis. Fabulous. The vast majority of you are right there. Let's just have a look back where we're just for the folks that weren't quite getting it, just to make sure you understand. So lead 1 here is predominantly positive. There's the baseline. Almost all of the Kuros complex is above that baseline. Lead AVF, again, here's the baseline. Everything above that is pretty much positive. They're both heading towards the cameras. So the cameras here, so lead 1 and lead AVF, they're both heading towards both cameras, so it can only be in this quadrant here, which is normal axis. Fantastic. So well done to the majority of you that got that. Okay, so sometimes, as I said before, so generally speaking, putting the axis into one of the 4 quadrants is enough, okay? But sometimes we do need to go a little bit more in detail, particularly, as I say, there are some cardiologists that would suggest that this 0 to -30 is technically normal as well. So sometimes it is nice to just know how much right axis or left axis deviation you're dealing with. Very rarely is going to make much difference to your practice, but sometimes it's kind of nice to know. So we'll throw this in here. So isoelectric leads. So every lead has an isoelectric brother, if you like. So if you imagine AVF here, AVF is looking down here, and basically what an isoelectric lead is a lead that's perpendicular. So every lead, every camera that's looking in at the heart has a partner that looks at the heart at exactly 90 degrees to it. And it looks in both directions, but obviously one is positive, one is negative. So it's no coincidence that lead 1 and lead AVF are isoelectric leads. They're isoelectric to each other. So if you're looking down lead 1, the only perpendicular lead is AVF. If you're looking up AVF, the only perpendicular lead is lead 1. Likewise. So lead 1 is isoelectric to AVF and vice versa. So lead 2, if we look up lead 2, we get to the point where it intersects at 90 degrees, and AVL. AVL is the isoelectric lead for lead 2. And lead 3, finally, again, we go along, and at some point it is going to be met by a 90-degree perpendicular lead, and of course for lead 3 it's AVR. So you can remember these fairly easily. If we go back to a picture of an ECG, effectively you just draw lines across this part of the ECG. So lead 3 is isoelectric with AVR, lead 1 is isoelectric with AVF, and lead 2 and AVL are isoelectric with each other. So you can kind of remember it as a bit of a cross on the ECG itself. And again, just a reminder here that leads, any kind of axis coming to, any kind of current coming towards the positive end of a lead is going to show as a positive deflection. Anything moving away is going to show as a negative. Anything perpendicular is going to be what we call an isoelectric or a biphasic QRS complex. And it's this that we're going to focus on at the moment. So when we want to differentiate a little in a little bit more detail about whether where within this quadrant the axis is sitting, we look for the lead that is giving us the closest to this, basically an isoelectric biphasic QRS complex. And by that I mean it's equal distant above the baseline as it is below the baseline. And generally speaking, in one of your 6 leads, you will find one of the leads is as close as possible to isoelectric, and we're going to pick the one that's closest. And in what you're doing is picking whatever quadrant or lead you're looking in, you're effectively picking the isoelectric lead for that view. I'm hoping this is making sense. It gets really complicated if it doesn't make sense. It's just a random words, isn't it? But do pop in the chat if I'm confusing anyone. I can re-explain it. So when we want to determine the axis a little bit better, so for all intents and purposes, being in one of the 4 boxes is enough. If you want to go into more detail, if you want to know whether we're closer to one of these sections within the quadrant, then this is what we look for. We look for the lead that's giving us the isoelectric current. So I'll pop that onto this slide, which is going to give it in a little bit more detail. And I'll draw on this slide a little bit more just to help you. So first things first, whenever we're narrowing down the axis, as it says here, we're going to look at what quadrant we're in here. So positive 1 and a positive AVF is going to put us into this normal quadrant. Hopefully everybody can see that nice and happily. The next thing we're going to do, because we want to figure out whether we're closer to this line or this line, now that we know that we're in this quadrant, we're going to look for the lead that's giving us the most isoelectric, i.e. the most same up as it is down, if that makes sense. Let me just get my my pen on the go here, and hopefully I can make that clear. So let me just get that colour there. So for all intents and purposes, I think so lead 3 here, you can see that this QRS complex is almost equidistant above the baseline as it is below the baseline. So lead 3 in this case is going to be the isoelectric lead. So if we're looking in this quadrant here, we know that our QRS complex sits in this quadrant somewhere. What we do, finding the most isoelectric lead, which is lead 3 in this case, we're going to draw a T shape across the quadrant. So the T shape is going to go, this is lead 3 here, and it looks up in this direction. All right, and we're going to draw a T shape with an arrow. Now the arrow of the T can go in 2 different directions. All right. By the fact that this is the most isoelectric, we know that the current is running perpendicular to this lead. So we know the current is running either in this direction down to this end, or it's moving in this direction. We know that the ECG axis is in this quadrant. So in this case, it can only possibly be running in this direction. So in this case, we draw the arrow of the T in this direction. So this is your T shape. The top of the T, the bar of the T always goes along lead 3, and the arrow, the pointy bit of the T, then goes into the quadrant that you know the axis is in. So you have to do step 1. You have to look at what lead 1 and what AVF are doing. These are both positive in this case, so we know we're in this quadrant. And then you're just going to find the most isoelectric lead, draw a T, pop it over this graph, or use this graph for reference. So the bar of the T goes along the lead that is most isoelectric. The fact that it has an isoelectric QRS complex means that the electricity is running perpendicular to it. Which direction it's running perpendicular to it in is determined by the axis, the quadrant of the axis that you know you're in. Is that making sense to everybody? Because I know it can get a bit it can get a bit complicated. Matt, so therefore AVF is purely negative because the current is running directly away from it. Absolutely. In a healthy heart, that is why AVR is always negative, because your SA node is up here, your AV node is here, and obviously your His-Purkinje system is all in that direction. So AVR, yes, you're right, AVR is always negative in a healthy heart. We'll look at extreme right axis deviation in a bit, which is where you get obviously positive waves in AVR. Hopefully that's making sense. We will have a chance to practice this in a little bit more detail when the slideshow decides to move on. Okay. Okay. So what we've done there in using the T-shape is getting the axis to the nearest 30 degrees. Now it is possible, and I've just put this in for information, it is possible to get it even closer than that. So this little graph here shows you how we do that. So your absolutely isoelectric lead is shown in the middle here. So if we know that, for example, in this case, if lead 3 was exactly isoelectric, we know, because we're in this quadrant, that the cardiac axis is plus 30 degrees. Okay, it can't be anything else. All right. Oops. Oh my goodness. I'm not getting on with this tonight. Okay. Bear with, folks, just some technical faults. There we go. Don't know why it's not running so smoothly tonight with the PowerPoint. So if the lead was exactly isoelectric, it would be exactly the same distance above the baseline as it was below the baseline, and we know that the current is running perpendicular to it. If you wanted to be a little bit more correct, because we can see, and actually this is a good example, lead 3, I would suggest, is slightly more negative than it is positive. Okay, so if that's the case, if the lead is slightly more negative than positive, we use this graph here. So we adjust the axis by 10 degrees. If it's significantly more negative than it is positive, then we adjust it by 20 degrees. We're only applying this to the lead that would be most isoelectric. So if it's obviously different, then we need to look around just to have a look to see if there's any other leads that are definitely closer. So in this case, lead 3 is slightly more negative than it is positive. So we're going to move the axis 10 degrees towards the negative pole, and this is where it gets slightly confusing. The negative pole of lead 3 is up here. It's at minus 60. So in this case, our true axis is nearer to plus 20. If you were to get it within the right 10 degrees. I'm hoping that makes sense to everybody. It's a bit of a whistle-stop tour. If you don't remember any of this, just remember that you only need to look at leads 1 and AVF to decide which quadrant it's in, and for 99% of patients, that's going to be absolutely sufficient. So here's an example for you. This will go up a Mentimeter again in a minute. So have a look at this rhythm. It's a bit of a mess. It's VT. And this is one of the few times where you might see this axis. So have a little look at what's going on here and see if you can determine, first of all, which quadrant we're in. And then if anyone's actually followed the last couple of slides on getting the axis within 10 degrees, if anyone can do that and figure out the cardiac axis to the nearest 10 degrees, then the answer will be up on Mentimeter in a minute. So have a look at that. Just get the Mentimeter slide active. So those of you that want to have a stab at answering this. There we go. So have a look at this axis. So to the nearest 10 degrees, what is the cardiac axis here? Have a look at your lead 1 and have a look at AVF. It's not immediately obvious. I give you that, but you should be able to figure out where the baseline is and where the QRS complexes are predominantly going. Once you've established which quadrants we're firing into, see if you can then figure out roughly what axis we're at to within 10 degrees. It can be done. It takes a bit of practice and takes a little bit of time to get used to what you're seeing. So have a look for the most isoelectric lead, just to get you on the right track. AVL in this case is the most isoelectric lead. And then we'll talk through it once some of you have had a go at answering. So your options: minus 100 degrees, minus 140 degrees, plus 40 degrees, plus 80 degrees. One of you has braved the question so far. Well done, some of you are answering it. Here we go. Okay. Some of you having a go with that. So I'm conscious of time. We'll start talking through it. I think that's probably stumped a few of you, which means I probably haven't explained the last couple of ideas quite so well. So we'll go back and have a look. But actually, well done. 67% of you, 71% of you getting that right. So, okay, maybe I have explained it better than I thought. So let's go back. Let's just talk through it for those of you that weren't so sure. So lead one here. Let's just get my pen up. So lead one is obviously up here. This is the baseline roughly, isn't it? This is some kind of T wave going on here. This is basically your baseline. So this is your QRS complex. It's almost entirely negative. AVF, exactly the same situation. This is kind of the T wave and a bit of baseline going on here. This is your QRS complex. It's predominantly negative. Two negatives put you in the extreme axis deviation quadrant, don't they? Looking at AVL now, AVL is our most isoelectric lead. It's the closest thing to above and below baseline. Everything else, this is all below, this is all below, this is all above. Okay, and remember when we said about AVR being positive, that should suggest something. So we are kind of in an isoelectric lead here. And if you look, I would suggest that it's kind of borderline significantly more negative than it is positive. I think there's definitely, it's easy to say that significantly more of that QRS complex is below the baseline than it is above the baseline. There's a bit of guesstimation involved in this. If there's just slight changes, we add or subtract 10 degrees. If it's a fairly obvious difference, we add or subtract 20 degrees. I'm going to go that that's a fairly significant difference between the positive and the negative deflection. So we're going to take 20 off, or we're going to put 20 towards the negative lead. So AVL here is our isoelectric lead. So we're going to draw our T, and obviously the arrow of the T is going in this general direction. Okay, and we're going to take 20 towards the negative lead, which is down here. So I made this roughly minus 140 degrees, which is what you came up with. So well done. Hopefully that makes sense. And that's it for axis, folks. That's really far more depth than you generally need for anything. So just remembering the 4 quadrants is enough. Absolutely, lead 2 was negative. Yes, John. Yeah. So finding the baseline just takes a bit of practice. In this case, VT isn't the easiest thing to look at, but if you see where, if you see the QRS complex is predominantly in VT, will give you a bit of a V shape. So where those V's meet is your baseline, in effect. It's hard. It was a difficult question. Again here, look for your V and where the V's meet. So this is a bit of T wave going on here. This is another QRS complex. This is a bit of T wave, QRS complex. So where your T waves are occurring, basically your baseline is in amongst that. It's not obvious, and that is quite a difficult one to work out. So well done to those of you that got that right. It's obviously a lot easier in normal rhythms that aren't VT. So well done. I'm glad it's making sense. So hopefully just that explained how we figure out the baseline. Yes, lead 2 is negative, John. So good, perfect. And AVR being positive is generally it's only going to be the case when you have an extreme right axis deviation, as we saw there. So bundle branch blocks. So again, we are probably going to run on a little bit this evening, folks. It always takes a bit of time to get the first subjects out of the way, but I need to work on my timing. So bundle branch blocks. So we've talked before at the beginning that when you come to the end of your His bundle here, we split into the right and left bundle. If we imagine that either of these got blocked, we would have alternate conduction through the heart. And we're going to look first of all at this right bundle branch block. So if the right bundle is knocked out, So the left bundle is going to depolarize as it would normally. So we're going to have a good, healthy depolarization. What we're going to find is slower cell-to-cell depolarization of the right ventricle, which is going to be slower. So there we go. So the left ventricle depolarizes as normal. So with the delayed right ventricular depolarization, we get this RSR wave. So what we're looking for in right bundle branch block is what's called an RSR wave. So you get a positive deflection as the left ventricle starts to depolarize. That starts to go back down towards the end of left ventricular depolarization, and then the right ventricle depolarizes through this slower cell-to-cell transmission. So you get a second depolarization spike, and that's what gives you this RSR that we talk about. You can see it in V1 here. It's generally more pronounced in V2 and V3, but these are in for the diagnostic criteria. And the other thing you get when we're looking, so in the right precordial leads, V1 to V3, you'll get this RSR pattern. And in your lateral leads, you'll see a slurred S wave, which is demonstrated here down here. It's obviously lead V6. This is what we mean by a slurred S wave. This kind of upstroke to the J point is almost a bit of a tick shape, if you like. So that's what we call a slurred S wave. So to diagnose right bundle branch block, all we're looking for is an RSR pattern in V1. It's generally in V2 and V3 as well. And we're going to look for the slurred S wave in the lateral leads. Okay. So what you can get is some ST depression and T wave inversion, because if you imagine that the ventricles are depolarizing in an abnormal way, they're also going to repolarize in an abnormal way. So to see ST depression and T wave inversion after an RSR complex in the right precordial leads is not abnormal in right bundle branch block, and it's nothing to be concerned by. So isolated right bundle branch block, it says here, does not generally affect the axis. It generally keeps, because the left ventricle is dominant. So actually you're still going to have a predominantly left axis, but it's just bearing in mind that you do get some swing, and we said at the beginning, generally all blocks within the bundle branches will cause a kind of leftward deviation to that axis. So that's a whistle-stop tour of right bundle branch block. It's generally nothing to be concerned about, and we've got this down here. So when you see I in brackets, it means incomplete. So two types of right bundle branch block. You have incomplete right bundle branch block and complete, and the only difference between the two is the width of the QRS. So it takes longer to depolarize both of the ventricles, because one side of it isn't depolarizing as efficiently as it would normally. So you get a wider QRS complex. So any QRS over 120 milliseconds is going to be a bundle branch block of some sort. But if you see this RSR diagnostic criteria, the RSR pattern in V1 and the slurred S wave in the lateral leads, but you have a QRS of less than 120 milliseconds, it is incomplete right bundle branch block. And it's wider because it takes more time. That's exactly right. So that's why the bundle branches will give you a wider QRS. So anything over 120 milliseconds in that case. So right bundle branch block, RSR pattern in the right precordials. It has to be in V1 for it to be diagnostic, and a slurred S wave in the lateral leads. Hopefully that's making sense to everyone. So the next one we talk about. So here's an example. Sorry, I forgot to put the examples in there. So, so what we're looking for in this case, saying it was more evident in V2 and V3. So we've got this RSR pattern here. So this is left ventricular depolarization. This is the right ventricle starting to depolarize. So you get that RSR wave. Again, here in V2, it's a little bit more pronounced, isn't it? So up, down, up. That's an RSR pattern. Up, down, up. RSR pattern. We've got this kind of widened S wave down here in the lateral leads over here. So that's diagnostic of right bundle branch block. Hopefully that makes sense to everybody. So left bundle branch block is the opposite, really. So your left bundle is blocked along here somewhere. So your right ventricle will depolarize as normal, and the left ventricle will depolarize by cell-to-cell transmission. Okay, so in exactly the reverse of right bundle branch block, if that makes sense. So you're still going to get this notching with the QRS complexes, because effectively you've got the two ventricles depolarizing at separate times rather than together. And it's going to be wider again, as we just talked about, because the left ventricle is depolarizing in a less efficient way. It's going to take longer. The QRS complex gets wider, And again, if you see the diagnostic criteria for left bundle branch block, which we'll talk about in a second, but the QRS of less than 120, it's an incomplete block. It just means that there is some current still getting through this bundle. We're going to talk about the anterior and the posterior fascicles very shortly. So the things to look out for in left bundle branch block are these deep S waves within the bear with me. Sorry, so the lateral leads. So tall R waves within the lateral leads and deep S waves within the right precordials. So in effect, it's the reverse of the right bundle. So leads V1 to V3, you're going to see these deep S waves. They're going to be wide, they're going to be notched. And in the lateral leads, you're going to see these really tall upright R waves. Again, they're probably going to be notched, they're going to be wide. And that is what we're going to use to diagnose left bundle branch block. We're going to talk about discordance in a bit more detail after because of the Sgarbossa criteria. That's what we use to ascertain whether discordance is normal. Discordance basically means the ST segment and the T wave travel in the opposite direction of the QRS complex. And this is something quite exclusive to left bundle branch block and left ventricular pacemakers. We'll talk about left bundle branch block for predominantly here. So left bundle branch block, you've got this big R wave. So where the R wave is positive, you're going to see ST depression and a T wave inversion. Where the S wave is the predominant wave, you're going to see some ST elevation and positive T wave. Hopefully that makes sense. It will make more sense as we go through later. And we've got the example of left bundle branch block here. So our diagnostic criteria, so these deep S waves in the right precordials are there. They're wide, it's more than 120 milliseconds, so it's a complete left bundle branch block. And then we're looking for these kind of big R waves in the lateral leads, so AVL, V6, V5, V5 less so, but V6 is diagnostic there. They're the two things we're looking for. Now this is discordance, and if anyone's kind of looked at ECGs with ST elevation and things like that, you might be sitting there thinking, is this an anterior STEMI going on? So this is what we mean by discordance. In left bundle branch block, where you get a deep S wave, you'll see ST elevation with a nice positive peak T. In reverse, in these lateral leads, for example, where you have a predominant R wave, you're going to see some ST depression and a T wave inversion. That is normal. That doesn't mean that this patient's having an MI. For a long time, people have been taught that you can't diagnose an MI with left bundle branch block, but we're going to talk about Sgarbossa criteria in a bit, which will help, hopefully, for people to make a diagnosis of MI when this discordance is called, when this discordance is abnormal. Okay. So the hemiblocks, so they're called different things. So the kind of correct way to call them is fascicular blocks. So we have the anterior fascicle and the posterior fascicle of the left bundle branch. And they can get blocks in just the same way as the right bundle and the left bundle can get a block. You can get a block within the fascicles as well. So it becomes a left anterior, left posterior fascicular block. So now these do give axis deviation, so it's worth bearing in mind. So the anterior fascicular block will give you left axis deviation, and the posterior fascicular block will give you right axis deviation. And basically that is all we can use to diagnose these. So you do get, so whenever you see complexes written like this, it means that the Q wave is smaller than the R wave. Hopefully that makes sense. So we use a non-capitalized letter for the Q and a capital letter for the R. It just means the Q is smaller than the R, and the R is smaller than the S. Hopefully that will make sense as we go through. But basically, what the most important things you're looking for with the fascicular blocks is the left and right axis deviation. So in leads 1 and AVL, you're going to see a small Q wave with a tall R wave. In your inferior leads 2, 3, and AVF, you're going to be looking at a small R wave with a big S wave, and that flips on its head with the posterior fascicular blocks. Okay, there is a bit of a warning there that when we're diagnosing, because we're basically only using axis to diagnose these fascicular blocks. So when you have an otherwise normal ECG with a left or a right axis deviation, it's generally going to be one of these things. But you do just need to make sure there's no hypertrophy, and there is a lecture coming up on ventricular hypertrophy later, because there's some diagnostic criteria for looking into that. We won't cover that today, but just have that in the back of your mind when you're looking at these axis deviations. Okay, so we have an ECG here, which is one of the I don't know if this is, oh no, fine, that's fine. So this is this wasn't part of the quiz. So this is left anterior fascicular block. Okay, so we can see that because there's a left axis deviation. So we have a positive one and we have a negative AVF. So hopefully everybody's confident that that is now a left axis deviation. So there's nothing else wrong with this ECG other than it's slightly irregular. So we're going to say that this is a left anterior fascicular block. And we can go through the other diagnostic criteria. So we're saying there's a small Q and a big R in 1 and AVL. Have we got that? So there is a bit of a Q wave there. There is a bit of a Q wave there. And of course the R wave is predominant. Okay. And again, is there a small R wave with a big S wave? So dominant S in the inferior leads. Absolutely. So dominant S, and dominant S. So but again, those items on their own aren't always there to help us diagnose. So in these cases, you're just looking for the axis deviation. So we have the opposite here. So what do we have? A predominantly negative lead 1 and a predominantly positive AVF. So everybody's confident this is a right axis deviation. A right axis deviation in isolation, you're generally going to be thinking of a left posterior fascicular block. Again, we have the dominant S wave, and the dominant R waves in the inferior leads to support that diagnosis in this case. Again, we're looking for any other causes of right ventricular axis deviation, such as right ventricular hypertrophy, which this ECG doesn't have, but we'll go into more detail about those at a later time. So hopefully that makes sense. So when we talked again about at the beginning of this, so bifasicular and trifascicular blocks, we said on last week's webinar that if you find a first degree heart block, just have in the back of your mind, could this be a bifasicular or trifascicular block going on? So what do we mean by these? So there's 3 points within the cardiac conduction system that you can, in theory, get a block. So one is the AV node, one is the right bundle, one is obviously the left bundle, but we can separate that down into left anterior fascicular block or a left posterior fascicular block. So these are the points that we can get blocks. So the AV block, the AV node, the right bundle branch, and the left bundle branch, which is obviously split into 2 posterior fascicles. So what bifasicular block quite simply means is a right bundle branch block plus either a left anterior fascicular block or a left posterior fascicular block. So we're going to diagnose right bundle branch block. We're going to look for axis deviation to make our diagnosis of a bifasicular block in those cases. So the term trifascicular block has 2 different types. So we have incomplete trifascicular block, which is bifascicular block, so right bundle branch block and either a left anterior or posterior heavy block. Plus first or second degree AV block. I remember when I said when we look at first degree heart block, the only thing that it could potentially be warrant, any further investigation is if there was a trifascicular block going on. Complete trifascicular block is a bifascicular block with a 3rd degree AV block. Okay, and I've got some of these coming up for you to have a look at. So 3rd degree AV block with bifascicular block is going to be worth a cardiac workup, certainly. And there's an important point to note here. So trifascicular block, which you find in a post-syncopial patient, so a patient that's had a T-lock or loss of consciousness of some sort, you do an ECG and you find a new trifascicular block that warrants cardiac workup. So you would be referring those people to cardiology. I'd imagine most of those patients are going to be elderly and going to be going into A&E anyway for routine bloods. If you're out and about in the community and going to be admitted if they're coming into your surgery. So any trifascicular block that's been diagnosed post-syncope is going to get cardiac workup. So we're going to have a look at some examples now. So bearing in mind, bifascicular block has to have a right bundle branch block plus left anterior fascicular block or left posterior fascicular block. And a trifascicular block is both of those plus either first, second or 3rd degree AV block. If it's 3rd degree AV block, it's known as complete trifascicular block. Hopefully that's making sense. It's lots of words. All these handouts will be available on the website as they have been the last couple of weeks for you to come back and look at a later date. So let's have a go working through a couple of these. So these are up on Mentimeter as well. I'll just get Mentimeter active. So you can vote there. It's the same number again. It's the same quiz running through. 330154. So we want to know, what is this ECG showing? So grab your smartphones. We'll have a look at this ECG and start to pop some votes in. So have a look. So first of all, with your ECG, first thing you're looking for is are any of the blocks, can you diagnose any of the blocks that we've talked about first of all? And we're going to look at the axis. Not going to look at the axis in too much detail. We don't need to go to the 30-degree rules or anything like that. We just need to know whether we're in one quadrant or another, and whether there's any other blocks going on that we can diagnose here. So having a look at that ECG, I'll give you guys a few minutes with that on the screen, and pop your answer in. I'm sorry, we are going to run over again a little bit tonight, folks. See how many of you have voted. None so far. Lovely, well done everyone. So starting to see some numbers come in. I'll pop it back over there. What's going on? What blocks have we got? So your options are right bundle branch block with a left anterior fascicular block, right bundle with a posterior fascicular block, just right bundle on its own, incomplete trifascicular, or complete trifascicular. What do we think it is? See where you folks are heading. Lovely, so most of you going for right bundle branch block with left anterior fascicular block. Let's have a little look. Let's go back. So we've got a right bundle branch block. You're absolutely right. So we've got this RSR pattern in the right precordial leads V1 to 3, and we've got this slurred S wave in the lateral leads going on, really evident up there in lead 1 and in AVL as well. This is what we mean by the slurred wave. So that's a really nice diagnostic right bundle branch block. And we also have a, bear with me, sorry, I think this is flipped forward. Yeah, it was the different ECG. It's handy, isn't it? So, yeah, again, as you can see here, we've got a right bundle branch block. We've got, and then when the next thing we're going to be looking at is the axis to see whether there's any hemi block going on. So we've got a positive lead 1, we've got a negative AVF, which of course means we have a left axis deviation. So you're absolutely right to say right bundle branch block with left anterior fascicular block. Lovely. So next one. And I helped you out there by starting off with, this is a very nice right bundle branch block, but what else is going on? Have a good look. So it's the same options again. Is this right bundle branch block with an anterior hemi block, right bundle branch block with a posterior hemi block? Is it just right bundle branch block on its own? Right bundle branch block with an incomplete trifascicular block, or right bundle branch, or is it a complete trifascicular block? Sorry. Have a look. See what you think's going on. So we've already established that there's a right bundle branch block going on. Lovely, a couple of you starting to vote now, so I'll pop it back there, give you a few more minutes to go through it. Just conscious of time, folks, so we'll talk through it. Okay, let's see where you guys are going. Oh, evenly split. Fantastic, okay. So some of you saying right bundle with left anterior, some of you saying left posterior, some of you saying incomplete trifascicular block. Let's have a look at what's actually going on here. If I can get the screen back. Okay, so we have a right bundle branch block. We've talked about that already. So we've got this RSR pass in the right precordials, and we've got this slurred S wave in the laterals. So we know we've got right bundle branch block. Have we got a hemi block going on? Let's look at the axis. So we've got a positive lead 1, we've got a negative AVF. That to me says that we are heading towards the left again, aren't we? So we've got a left axis deviation. And what else do we have here, folks? So we've got right bundle branch block, left anterior fascicular block, because we've got a left left one axis again. Have a look at these P waves. That PR interval. So P long PR interval, P long PR interval. It's nice and regular. That PR interval is not changing. That's a first degree heart block. So what do we say if we've got a bifasicular block with a first degree heart block? We have an incomplete trifascicular block. Hopefully that makes sense to you, everybody. Fantastic. As I say, all these slides will be up on the website. If there's anything that hasn't made sense, do feel free to drop us an email, pop a chat in, or we can do the interactive Q&A at the end of the session, which is not far away now. So just one more ECG interpretation for you this evening, and then we are going to talk about Sgarbossa very quickly. So this is just a quick case study. 26-year-old male, normally fit and well. He's just here for an Ocky Health medical. He comes in asymptomatic. Healthy lifestyle, all his obs and everything is normal. You do a routine ECG. This is what you see. What's going on? What is this rhythm? What is this this ECG showing us? No trick questions. It's up on Mentimeter. What's the ECG showing? Have a vote. Have a quick look. Good, some of you having a go. So is it right bundle and left axis, right bundle and fabulous. Well done, folks, getting it there. So it's a bit of a strange ECG, actually, but you are getting the right answer. Bit of a strange ECG. I say that because it is just right bundle branch block. Can't actually really see any P waves in there. And actually this axis is actually up in the extreme right axis deviation. I'd like to know what the genuine history was behind this ECG to figure out what was going on. But in this case, it is just showing right bundle branch block for the purposes of there. So well done, well spotted. And 56% of you getting that. But I think that would warrant some further investigation, idea about this right axis and no P waves, whether it's some kind of junctional escape rhythm or something that we'll talk about in a future video. So well done. So Sgarbossa. This will be the last section, folks. I know we have run over again, so my apologies. But hopefully it's all useful for you. Scarbossa's criteria sets out 3 different criteria for trying to, and when we're going to use these is a patient with left bundle branch block that we suspect is having an MI underneath it. Because for a long time we were told that you can't diagnose an MI on a left bundle branch block, and Sgarbossa, Elena Sgarbossa in 1998 proved otherwise. So here we have Scarbossa's criteria. So the most, they're awarded points, so 5 points, 3 points, and 2 points for C at the bottom there. So the original rules were that any, so remember we talked about discordance. So discordance is basically the ST segment and the T wave going in the opposite direction of the general QRS direction, if that's making sense still. So when we say concordance, that is that the ST segments and T waves start to move in the same direction as the QRS voltage. And in a left bundle branch block, that's abnormal. You shouldn't see concordance. So ST segments and T waves going in the same direction as the QRS voltage, that is abnormal, that's concordant. If you see ST elevation, concordant ST elevation of equal to or more than 1 millimeter in any one lead on a left bundle branch block ECG with a patient you suspect of having an MI, that's 5 points. That's a definite, that's, you know, it's as definite as an MI as you would see anterior elevation on an ECG with a patient sitting in front of you having chest pain. Okay, and we're going to talk about a lot more next week. So this will just be a whistle stop tonight. So again, the word concordant, so ST depression going in the same general direction as the QRS complex. So if you see a predominantly negative QRS and you see some ST depression, this ST depression is abnormal. Any one lead, V1 to V3, and if you see it in those leads, that gets you 3 points, that gets you to the cath lab. Okay, so the C and modified C, originally rule C said basically excessive discordance. So remember, discordance is ST segments and T waves going in the opposite direction to the QRS voltage. If it's more than 5 millimeters in any one lead with a negative QRS, then that was positive. So since then, we found out that C on its own wasn't very specific, actually, for finding MIs. So Smith's criterion came along and they made this modified C rule, and this is the one we use now. We don't use this old C anymore. We use modified C, Smith's C, which is that actually the discordance, if it's more than 25% of the preceding S wave, then that is diagnostic of MI. Okay, so what that means is this preceding S wave, this is any lead with a negative QRS, and I'll flick to another view in a minute, which makes this clearer. Any lead with a negative QRS, if the ST elevation, for want of a better word in this section, is more than 25% of the depth of this S wave. So if this S wave was 20 squares deep, for example, if this was more than 5 squares tall, which is in this case, that would be diagnostic of an MI. I'm going to pop up this screen because this just helps us look through it. So this is a typical left bundle branch block ECG, the one we saw a little bit earlier when we talked about it. So we know it's left bundle branch block because we have these deep S waves in the right precordials, and we have these wide R waves in the lateral leads. So we know this is left bundle branch block. We've also got some left axis deviation just to confirm that for us. So we're going to apply some of Sgarbossa's criteria. So all these leads that are positive, so that's your lateral leads, if you were to see any ST elevation in any of these lateral leads, that is a big red flag. That's 5 points. Go to the cath lab, collect £200 on the way. All right. Any lead where it's predominantly negative, so your bottom inferior leads here, your anterior leads, if you were to see any ST depression in any of these, in V1 to V3, if you were to see any ST depression in V1 to V3, that would be a big red flag. If you were to see disproportionate discordance, so if you were to see ST elevation of more than 25% of this depth of this S wave in any of these leads, then that would also be a red flag. So the S wave here is, say, what are we, 25 squares, just nearly 23, 24 squares. This ST elevation would have to be more than 5 or 6 squares for this to be diagnostic. In this case, the S wave is even bigger. We're kind of almost 30 squares. So you'd have to see at least 7.5 squares of ST elevation in lead V2. It's a whistle-stop tour. We'll talk about it more next week. I'm aware that we are kind of running out of time. So this is Sgarbossa's criteria. This is an example. So we were talking about inappropriate ST elevation. You can see actually, and it only has to be in one lead with Sgarbossa. So we've got inappropriate ST elevation and more than 1 square in lead AVL here. That's diagnostic of an MI. This one looks weird, so you'd expect, because these leads are predominantly negative, you expect the ST segments in these anterior leads to be positive. It's not. So we've got some anterior ST depression. That is diagnostic of an MI. Okay, I couldn't find any good examples of C, but it is more rare, to be honest, of inappropriate discordance. But it's just bearing in mind that it's there. If you see massive ST elevation in any of the leads where the S wave is predominant, then you need to be thinking, is it more than 25%? And again, we treat the patient, not the numbers. These are patients that you suspect of having an MI. And this is, I submit this as possibly the Eton triage tool. This is something I worked on for a project within one of the trusts I worked for recently, around how we actually triage our left bundle branch blocks in the community, because they're notoriously difficult. So suspect ACS in a patient, you see left bundle branch block on an ECG. Whether or not you go to the acute MI pathway, so depending on your local trust, whether that's down to the heart attack centre or CCU or along those lines. So the pathway here was if they're hemodynamically unstable with acute heart failure, whether or not this left bundle branch block is new or old, we go to the hack. Sgarbossa's score of more than 3 or more, so that's criteria A or B. And then the final check was to do this STS ratio. So that was if the ST segment was elevated by more than 25% of the depth of the preceding S wave, then we also go off to the heart attack centre. If it's no, then we go to the A&E department with the ACS care bundle. But again, we will talk about that in a little bit more detail next week. But that was Sgarbossa criteria. And that, you'll be pleased to know, brings us to the end of tonight's webinar. I'm sorry it has run over again, and that was a bit of a rushed tour of Sgarbossa at the end, but we will pick up on that again next week. So for those of you that don't want to join in the Q&A, that is about to start. You can leave. There's nothing. You're not going to miss anything now. The Zoom links again for next week will be done in exactly the same way. We'll pop them up on Facebook and on our website in plenty of time. The next episode is at the same time next week on acute coronary syndromes, and we will go back over the Sgarbossa criteria as part of that. So don't worry too much about that. So Charlotte's very kindly just popped in the links to leave us a review. I would be really grateful if you would mind leaving us a review. Obviously, we are doing this free. I apologise, we've had a couple of technical issues tonight with the slides not progressing at the right pace and so on and so forth. Hopefully I haven't confused anyone too much with access, because it is a bit of a big subject. But we get on to much more kind of logical and clinically appropriate stuff for the next few weeks. But as always, any questions when you leave us, webinars@stctrainingsolutions.co.uk, and the Q&A session comes up next. So thank you to those of you that are leaving us now. We look forward to seeing you next week. Obviously, if you missed any of it, it will be up on our YouTube channel, on our website in the next day or two. The handouts, we will be producing the same handouts we've done over the last couple of weeks. They'll go up on our website within the week. Q&A session then, so feel free. Anything you want to ask, folks, you can do it through Menti. You can pop it into the Zoom chat. You can WhatsApp us. You can email us. You can tweet us. You can do whatever you like. So I'm just going through the chat to see if anyone. So you're more than welcome, everybody. Everyone that's saying thank you. You're more than welcome. We'll hopefully see you again next week. And yes, we will be for Wendy. We'll be popping the videos up onto YouTube. I know there's some quite heavy subjects in there, and you can't really whistle stop to all them that easily. So any questions from anyone? Mentimeter or the chat are probably the easiest way. I've got those both in front of me. No questions this evening? Either we've explained it very well or I've bored everyone to death. Lovely. Well, if there's no questions, in that case, fab. Yeah, just more time. I think we'll certainly touch on Sgarbossa again next week, Wendy, if you're still struggling with it, because I think it fits in nicely to the acute coronary syndromes. Axis, as I said, don't get too bogged down with getting it to the nearest 30 or the nearest 10. I mean, I've never needed to do that. It's just nice to know how it works. But if you've no interest in that, then I wouldn't bother learning it. It's more of a just get it into the right quadrant, be able to spot when you have left and right axis deviation. But to know within the nearest 10 or 30 degrees is very rarely necessary. So when you can go back and review it. Yes, CPD certificates, same again. Webinars@stctrainingsolutions.co.uk, and we can get those arranged for you. More than welcome, Matt. I'm glad it's making sense. It certainly didn't make sense the first time I learned these subjects. So. Just having a look. Let's see some. Thank you, John. That's appreciated. Fab. So just saying, is this FREC 5 material? This is, I would suggest what we're doing tonight is probably aimed more at FREC 5s than at kind of FREC 4 and lower. But then again, it really is determined on where you're working, really. So these whole webinars are aimed at people that are expected to interpret ECGs as part of their practice. So ordinarily, FREC 4s aren't going to be expected to do that, although it's nice to know, certainly. So yes, it doesn't have your first name on there, just your iPad. But yeah, no, it is aimed more at FREC 5s, I would suggest in that case. So you're doing, oh, Alan, thank you. Yeah, so you're doing the training at the moment for FREC 5, wonderful. Yeah, so this will come up in your FREC 5 ECG interpretation of some sort. You're effectively trained to technician-ish level, aren't you? So as FREC 5, so that's ECG basic recognition is going to be part of that. Yes, and absolutely great to have the background knowledge when you're working with text and powers, Andrew, exactly. So whilst it's not part of the FREC 4 basic teaching, it is very useful to know, and as I say, there's no such thing as knowing too much. Fantastic. So I think if there's no questions on the subjects, then we'll close it off this evening, folks. As always, you can contact us during the week as well. Our standard contact details are all up there. So webinars at STC Training Solutions, we'll answer that as soon as we can. You can WhatsApp us and tweet us. Obviously, contact us through our website, etc. If there's anything you need. So. And we'll pop this up onto YouTube over the next day or two, and the handouts, as I say, by the end of the week will go up on our website. If there's anything you didn't understand from tonight, if you want clarification, feel free to give us an email, and we'll do our best for you. So thanks for coming along. Enjoy the rest of your bank holiday Monday, and we'll see you again same time next week. Okay, thanks guys, bye bye now.